Well, hello guys. Today I'm going to discuss oral antidiabetic agents. So straight away, let me jump straight to it. So, first of all, let's try to understand this image that's been displayed here. As you can see, the words displayed in red, like highlighted in red, show the different effects that can be brought about by the different classes of drugs as they carry out their mechanism of actions. So these drugs enhance insulin secretion. Then these drugs, the big guanides and thiazolidinediones, overcome insulin resistance by increasing insulin sensitivity. Then these drugs, the alpha glucosidase inhibitors, retard carbohydrate absorption, meaning like they decrease the absorption of glucose, maybe via GIT, or they can inhibit enzymes that break down maybe like starch to glucose. Now like the pancreatic amylase, they inhibit the pancreatic amylase that breaks down starch to glucose. So in simple terms, you'll not be absorbing that glucose from starch. So and in simple terms, it brings about that effect of retarding the carbohydrate absorption. Then this effect, the miscellaneous drugs are like other drugs, the other drugs that act via other mechanisms. I mean, like that bring about the decrease in blood glucose through other mechanisms. So let's begin with these ones that enhance insulin secretion. So the antidiabetic drugs that enhance insulin secretion are known as insulin secretagogues. But actually, the insulin secretagogues, the main insulin secretagogues are the potassium dependent, like ATP, the potassium ATP dependent blockers, channel blockers, the potassium ATP dependent potassium channel blockers. So these ones are known as the insulin secretagogues, and are divided into two: the sulfonyl ureas and the meglitinides, right? So the only insulin secretagogues are the sulfonyl ureas and meglitinides, though they can include the peptidase 4, but the main ones are these ones, the sulfonyl ureas and the meglitinides. So let me try to explain the mechanisms of action. First of all, the sulfonyl ureas, like they are divided into two. They are those of the first generation and the second generation. Those listed here are of second generation, and they are the most drugs used because they are more potent and they have few adverse effects and drug interactions. As I had said earlier, the insulin secretagogues, what they do is to bind to the sulfonylurea receptor SUR1. They block the ATP sensitive potassium channels, resulting into depolarization. So this depolarization results into the opening of voltage gated calcium channels, which eventually results into a calcium influx. So now the calcium influx results into release of insulin, obviously, as you can see here, enhance insulin secretion. That is it. So these ones, the sulfonyl ureas, are used for, like, to treat type 2 diabetes mellitus, that is the non-insulin dependent diabetes mellitus. Yeah. Then the adverse effects associated with the sulfonyl ureas include hypoglycemia, that is in case they're given in excess. Another one is weight gain. Yeah. So that is all. We go to the next ones, the meglitinides. These ones are also they're also insulin secretagogues, and their mechanism of action is also similar to the sulfonylureas. Though these ones also block the ATP sensitive potassium channels, cause depolarization. Then the voltage gated calcium channels open, resulting into a calcium influx, and they also trigger the calcium release. So the mechanism of action of the sulfonylureas and the agglutinides is similarly the same, right? So basically that is it. Then maybe if I am to talk about the indications, these two drugs are used to treat type 2 diabetes mellitus, but these ones have a faster onset and a shorter duration of action. And they're usually given to patients with like irregular meal schedules and stuff like that. The adverse effects associated with the agglutinides is hypoglycemia. So in both you see hypoglycemia as the adverse effect, though with this one it's associated with weight gain. Yeah, that is it. So we jump to this one. No, let's go to this one, the dipeptidase 4 inhibitors. The dipeptidyl peptidase inhibitors. So these ones include the sitagliptin, vildagliptin, saxagliptin. So you should know what, first of all, the dipeptidyl peptidase 4 does. So dipeptidyl peptidase 4 is responsible for the proteolysis of incretins. What are incretins? Incretins are hormones that function to decrease blood glucose. An example of an incretin is glucagon-like peptide 1. Another one is glucose-dependent insulinotropic peptide. So these hormones, like, they function. Actually, they're like insulin, right? But they're not insulin. So what their function mainly is to like decrease blood glucose, right? So dipeptidyl peptidase is an inhibitor of dipeptidyl peptidase is an enzyme. Dipeptidyl peptidase 4 is an enzyme that breaks down those incretins, the hormones that do what? Reduce blood glucose. I think that makes sense. Dipeptidyl peptidase is an enzyme that breaks down the incretins that decrease the blood glucose levels, right? So these dipeptidyl peptidase, they are responsible for the breakdown of the incretins, including the GLP-1, that is glucagon-like peptide 1, and the glucose-dependent insulinotropic peptide. So these agents inhibit that dipeptidyl peptidase 4 to increase the active incretins. Are you seeing? So if you inhibit those that break down the enzyme that break down incretins, so the incretins will be able to do what? To carry out their function, and as a result it will result into an increase in the insulin synthesis and the release, and it suppresses that of glucagon production in a glucose dependent manner. So as a result, there will be in simple terms, there will be a decrease in what? In blood glucose levels, because the incretins will be allowed to accumulate, and they carry out their functions. So it is simple, as you can, as I've explained. So these drugs are given to patients of diabetes type 2. The adverse effects include rhinitis, that is running nose, and maybe upper respiratory tract infections. Yeah, that is it. So we go to these effects, those like the different classes of drugs that result into overcoming insulin resistance. So these drugs, what they do, they increase insulin sensitivity, right? First of all, one of the drugs under here is a biguanide. The biguanide, it's a specific class, biguanide, that is AMP kinase activator. So physiologically, AMP kinase is related to reducing hepatic glucose production, meaning like conversion of glucagon like glucagon stores, I mean, no, glycogen, not glucagon, but the glycogen stores in the liver to glucose. So what these big guanides do, they prevent the conversion of glycogen into glucose, which is like then taken into blood to increase blood glucose levels. So the big guanides like prevent the conversion of glucagon to what? I mean, no, prevent the conversion of glycogen to glucose. Yeah. So another thing is they prevent or reduce intestinal absorption of glucose by activating this AMP kinase, right? So AMP kinase has different, like AMP kinase activator, like this big one, it is an AMP kinase activator. AMP kinase functions to prevent or reduce the conversion of glycogen to glucose, and also to reduce the intestinal absorption of glucose. As simple as that. Therefore, increasing the insulin sensitivity and thus overcoming insulin resistance. Simple. So it is indicated or like given to patients of type 2 diabetes mellitus. So the adverse effects associated with the big guanides include let me see, GI distress, yes, GI like GIT distress, gastrointestinal distress, and also causes lactic acidosis. Yeah. So we'll continue to these ones, the thiazolidinediones. Like these ones, they are called the PPAR gamma activators. PPAR gamma means peroxisome proliferator activated receptor gamma. And what these drugs do, as I had said, they are, they sensitize insulin, like they are insulin sensitizers. They allow the cells to be sensitive to insulin by decreasing insulin resistance. So they have different functions. They have different functions in different organs. For example, maybe the liver, the muscles, and adipose tissue. In the liver, they decrease the glucose output. Then in the muscle, they increase glucose uptake. Then in the adipose tissue, they increase glucose uptake and decrease fatty acid release. Simple as that. They're indicated for, they are given to patients of type 2 diabetes mellitus, and their adverse effects are related to edema and weight gain. Yeah, as simple as that. So now go to these ones. These ones that retard carbohydrate absorption. Those that retard carbohydrate absorption, you have the alpha glucosidase inhibitors. As I had said earlier, these ones function like to inhibit specific like enzymes in the GIT that increase blood, like that result into the conversion of maybe like starch to what, to glucose. For example, the alpha amylase in the pancreas, which is like a pancreatic enzyme. So like this alpha amylase converts like starch to glucose. So it, like this enzyme like inhibits that process of conversion of starch to glucose by alpha amylase, and it also inhibits prolongs, it also prolongs the, so this alpha glucosidase inhibition, alpha glucosidase inhibition also prolongs the digestion of carbohydrates, meaning like there will be a prolonged breakdown of carbohydrates, and as a result there will be decreased absorption of glucose, which decreased absorption of glucose results into a decreased levels of glucose in blood. So that's how they usually like carry out their mechanism of action. Yeah, so they indicated for type 2 diabetes mellitus patients. Adverse effects are associated with GI distress and flatulence. Flatulence is like accumulation of gas in the stomach or in the GIT. in simple terms, but flatulence is like gas in the GIT. Yeah. So yeah, that is it. Then we move to the miscellaneous drugs that act through other mechanisms. Here we have the sodium dependent glucose cotransporter 2, and these ones, like these agents, inhibits the sodium dependent glucose cotransporter 2 in the proximal renal tubules, right? So what they do is like they result into reduced reabsorption of filtered glucose from the tubular lumen and lower the renal threshold for glucose, right? So like they don't, these ones, remember, like in the renal tubule, like the glucose that that is filtered via the glomerulus and the Bowman's and the Bowman's capsule, they say like 100% of that glucose is taken back into our body in the proximal tubule. So but when you block these channels, like this transporter, the glucose will be lost in blood, like in urine. It is lost in urine. So like the plasma glucose levels reduce like through that process. So there is a reduction in the filtered glucose reabsorption, and it lowers the glucose that is reabsorbed, which results into increased urinary excretion of glucose and reduces the plasma glucose concentrations. As simple as that. The examples are here: the dapagliflozin and canagliflozin. Then they are indicated for type 2 diabetes mellitus also. If the adverse effects are related to genitourinary infections and increased serum potassium, that is hyperkalemia. Then these other ones, the dopamine 2 agonists. And examples here we have bromocriptine and carbagolin. So these ones, they act via the dopamine 2 receptor to what? To inhibit, that, yeah, they act via the dopamine, like D2 receptors, to inhibit glucose what? Yeah, glucose absorption. Like, yeah, that is it. Thank you.